Today's class is on rheumatology and it will be taken by Dr. Varun Pushkarna.
Good evening, doctors. Uh, all those who have been with us in the last two lectures, I think we've finished up to the arthritis part. Uh, we've done the ankylosing spondylitis also. Anybody from the previous class? We'll begin with ankylosing spondylitis. So, in MRCP exams, you have to remember that rheumatology carries a lot of significance because of the heightened awareness about rheumatology in UK. Basically, it is one of the flag bearers for rheumatology worldwide. So we have to remember that they tend to associate all diseases with rheumatology. So be it pericarditis, be it rheumatoid, be it arthritis, be it spondylitis, be it skin and related diseases and pyrexia of unknown origin, many times you. So basically, what you will see is that even if it is 15 questions that are expected to come from rheumatology, you will find around 20-25, including some questions which are directly from rheumatology, few of them as surrogates of rheumatology, like interstitial lung disease, pulmonary fibrosis, and then in pharmacology and epidemiology and those statistics, biostatistics, and all. So you will find more questions than promised in from rheumatology. That is why many people they just uh, later on realize that rheumatology we should have done in a better manner. We've done all sort of things in the previous classes. We've done psoriatic arthritis, we've done reactive arthritis, we've done osteo. This is all that we have done already. So today we'll be doing the leftover parts, including vasculitis and some things that we did not finish in the last class. So ankylosing spondylitis. Ankylosing means fusion. Spondylitis means anything pertaining to the spine or the axis of the body. It is a chronic inflammatory progressive disorder. Sorry for not mentioning progressive here. It basically affects. Can you see the screen, everyone? I mean, just turn on your mic and tell me if it is.
Yes, sir.
Great. So, ankylosing spondylitis, it basically begins in this butterfly area, which is we understand that this is the pelvis, and this is where it actually starts. Ankylosing spondylitis usually starts at this area, which is known as the SI joints, sacroiliac joint, and then between the junctions of all the vertebrae, it progresses, leading to bamboo spining of the whole spine, along with fixation of the sacroiliac joint, which restricts the mobility. So basically, it is the fusion of the flexibility and hence leading to stiffness. So most of the people are young, they are between 15 to 35 years of age, and they are usually men. It is associated with the HLA-B27, like we last time studied the pair diseases, which is psoriatic arthritis, ankylosing spondylitis, IBD associated arthritis, and reactive arthritis. They are all HLA-B27 associated arthritis. So mainly what we see is arthritis. Arthritis means synovitis, means wherever the bones they join with each other, at that point there is inflammation. Here it is sacroiliac joint inflammation. There is spinal fusion due to constant bone erosion and healing, spur formation. The problems start happening when the fusion starts happening. So costovertebral, costosternal. So many times you will have people coming to you with pain on the left side of the chest, worried that it could be a cardiac pain, but then it is like costochondritis that we keep saying. It could very well be ankylosing spondylitis because we usually remember sacroiliitis, but we tend to forget that costovertebral and costosternal joints may also be involved, leading to ankylosis. Also, in these patients, is very common is enthesitis. Enthesitis, that is these tendons which are the point of insertion of a muscle's belly into the bone, gets inflamed, leading to a condition known as enthesitis. Now, this enthesitis can occur in a hand where the fingers are unable to move or they become stiff, or in the, as you can see here, it is the Achilles tendon which gets inflamed. As far as the symptoms are concerned, the spine, it is an inflammatory disorder. So remember always, stiffness will take over pain to much higher consideration, and it is more and worse in the morning and should last more than 30 minutes, the early morning stiffness, not only in rheumatoid arthritis, but in ankylosing spondylitis also, that gets better with activity. So this is the silver lining, that if these people continue to have good physical movement, they might have improved quality of life, leading to stiffness eventually, which may lead to a stooped posture. And you must remember, and it will be there in the exam, in the question, that these patients were tested for Schauber's test. And you need to remember Schauber's test, that is, we just tend to have a person stand by the wall and tell him to bend over, and then we measure the angle of flexibility. This demonstrates limited spinal flexibility. There is decreased chest expansion because of the involvement of the costosternal and the costovertebral joints. There is decreased chest wall expansion. Never forget that. It is an important test. Along with the joints and the tendons, the another joint, another organ involved is the eyes, which can have anterior uveitis, leading to photophobia, watering, and redness. That is, painful redness of eye may lead to blindness if not treated. Along with that, another organ involved is aorta, which leads to aortic regurgitation and consequent diseases, along with apical pulmonary fibrosis. So don't forget that lung also gets involved in ankylosing spondylitis, leading to the fibrosis of the pulmonary apices. So workup, you must remember that X-ray of the SI joint is the gold standard. Don't mark MRI. Okay? MRI of spine is not the gold standard. Although it might be the best and most accurate test, it is not the gold standard. Gold standard is X-ray. X-ray is recommended as a first line imaging by the NICE guidelines. It is gold standard also because of its accessibility, ease of getting it done. It can be used to diagnose ankylosing spondylitis. I'll give you a homework. Fill it up, that X-ray of ankylosing spondylitis staging. So you will find out how the ankylosis can be seen on the X-rays. MRI is considered to be appropriate if sacroiliitis is not detectable on X-ray. Why? In very early stages, there is only something known as bone marrow edema. There is something known as bone marrow edema. Now, this bone marrow edema cannot be seen on the X-ray. What will be needed is MRI of the joint. So MRI will tell you that, okay, fine, there is no ankylosis at the moment, but the bone marrow edema has started. Hence, the diagnosis is ankylosing spondylitis, and this helps us to diagnose it very early in the stage. And hence, getting an MRI is not criminal. Getting an MRI is tactical. When you get it done, you decide that my patient has an element of sacroiliac stiffness, and although he does not have any signs or features of sacroiliitis on X-ray, I am pretty sure that this patient has early stage ankylosing spondylitis. So let's get an MRI done. Once you get an MRI done, you can start the treatment early and also prognosticate the patient. So MRI of LS spine is most accurate. Why? Because of the bone marrow edema. Always remember this. Do not forget this. It will be there in the exam. Why MRI is better than the X-ray? It is because X-rays do not pick up the bone marrow edema, and MRI will pick it up at the earliest possible. Other findings are bamboo spine, which is fusion of the vertebral joints to each other. The problem is by the time bamboo spine happens, the patient is already like a bamboo. So there is no recovery from that point onwards. HLA-B27 can be seen in 90% of the patients, and this has come in many times in MRCP exam. This figure of 90% is very important. You must not forget it, because many times people just say it out of their memory. Okay, 50%, okay, 70%. No, it is 90% associated with ankylosing spondylitis, the HLA-B27 positivity. It is not intended for diagnosis. It is just a supportive evidence. It is just a supportive evidence to rule out other causes of spondyloarthritis. Treatment, as I told you, because there is an element of improvement with physical therapy will be a cornerstone for managing ankylosing spondylitis from the day one, along with exercise. Non-steroidals are the drug of choice. Which non-steroidal? Anyone? Anyone? Which non-steroidal is classified as first drug to be started in patients of ankylosing spondylitis?
Naproxen.
Wonderful. So the drug of choice is naproxen. Many times there is mention of ibuprofen, indomethacin, and COX-2 inhibitors. But remember that you have to know that out of all these four, all of them are non-steroidal drugs, but the first line of treatment is naproxen. Mind you, you can give it daily for a span of even 3-4 years without any significant gastric side effects and an improvement in the quality of life. Remember, this is a progressive disorder, so you will need to be on the tenterhooks. You will be on the watch out for any worsening of the disease, but some patients may remain stable on just naproxen. So consider first line treatment, that is naproxen, for managing pain and stiffness. If not, then progress to TNF inhibitors. I tell you, they are wonderful drugs. I have 2 of my patients on adalimumab, 40 microgram every second week, and they are doing wonderfully well when they were just having complications because of excessive use of non-steroidal drugs. One of them had a very bad GI bleed, leading him to a hemorrhagic shock, and eventually his hemoglobin was only 3 grams when he presented to the hospital. But now he's very happy because he's on adalimumab, and it is now literally considered as the second line therapy and a second line drug of choice. Long-term complications like any other arthritis, and people who have been on non-steroidals and sometimes on steroids, are low bone density, osteoporosis, osteopenia leading to vertebral fractures, and sometimes injury to the spinal cord. Restrictive lung disease, lung fibrosis. Remember, it is the apices which are involved. So apical lung fibrosis can be hinting towards it. Aortic valve regurgitation is a complication, and many times people die of it. Blindness due to recurrent uveitis can lead to this. So there are certain pearls for MRCP. They were not asked earlier on, but now that the questions asked from these are increasing, that is why I've specifically kept them. Those are the Bath indices, the BASDAI, or the Bath ankylosing spondylitis disease activity index. We all remember DAS28, which is the condition for which DAS28 is used.
Rheumatoid arthritis.
So that is used for rheumatoid arthritis, and Bath indices like BASDAI, they are used for ankylosing spondylitis. So it is a validated diagnostic test, and also it helps to determine the effectiveness of current drug therapy and planning to shift the therapy from non-steroidals to disease modifying biologicals. Then there are certain functional indices, activity indices, metrology index. I've just kept them for your reference. BASDAI, BASFI, BASMI, BASG, all of them are there. But then BASDAI is asked again and again. Is that clear? Ankylosing spondylitis? Okay. So now we move on to the next topic. We will do the questions also. If you want, we can do questions alongside, but I'll have to find where these questions are. Yeah. Okay. Okay. So we have them here. So it will be just, what do you say? Where is ankylosing spondylitis? It will just be few questions for you so that you can remember them. I think there are new students in this class, because otherwise if they were from previous class, they would have helped me remember where we left in the last one, because this is the red pen and we taught the last class with the black pen. Okay. All right. I would like you to participate. A 24-year-old man presents with chronic back pain and morning stiffness lasting more than an hour. He has a family history of similar condition. X-ray shows sacroiliitis. What is the most likely diagnosis? Cakewalk and ankylosing spondylitis. Okay. A 30-year-old woman with history of psoriasis presents with joint pain and fingers and toes. So this is pair or all HLA-B27. Physical exam reveals dactylitis and nail pitting. Which of the following is most characteristic of her condition? Sausage digits. Okay. Can anyone tell me, now that you guys are new, can anyone tell me, if I have to differentiate between rheumatoid arthritis and psoriatic arthritis, which joint involvement would tell me that this is not rheumatoid arthritis?
Distal
DIP. Distal
Wonderful. So
intercostal.
it is the DIP. If the DIP is involved, it is not rheumatoid arthritis. Although if PIP is the only joint involved, it can still be psoriatic. But if the DIP is involved, just DIP, or with PIP, DIP is also involved, then it goes out of the ambit of rheumatoid arthritis. Then it becomes more of a psoriatic arthritis. All right. Basic question. A 27-year-old man develops knee pain and conjunctivitis 2 weeks after a GI infection. What is the most appropriate treatment? So this is reactive arthritis.
Yes,
Remember, for pair diseases, it is the non-steroidals which are the drug of choice. Many people start these patients on steroids right away when it is not the right way of managing. It should be non-steroidals. And as I told you, naproxen works excellent even in ankylosing spondylitis and in these diseases. All right. A 35-year-old man with Crohn's disease presents with joint pain and swelling in the ankles and knees. Which type of arthritis is he most likely experiencing? So the answer is?
reactive arthritis. Enteropathic.
It is enteropathic arthritis. It is also known as IBD associated arthritis, IBDA. Okay. All right. Just a quick memory question. What is the percentage of HLA-B27 involvement with ankylosing spondylitis?
90%.
90%. Wonderful. A 45-year-old man comes with lower back pain and stiffness that improves with exercise. He also reports episodes of eye redness and pain. What genetic marker is the most associated condition? It is
27.
HLA-B27. Okay. So let me give you a question. A young boy 20 years old, diagnosed with ankylosing spondylitis 2 years back, was stable on naproxen 500 milligram daily since last 2 years. Recently, he had a GI infection, and since then, although he has recovered from GI infection, his back stiffness and pain have worsened. What is the next line of management?
Sir, TB gold interferon test followed by adalimumab.
Wonderful. So this is what I was expecting. We have to rule out that this patient does not have TB, this patient does not have HIV, hepatitis B, hepatitis C. So for all these tests we do and then move on to adalimumab. All right. So please be very, very careful. They will have first answer as adalimumab, and this will be somewhere third or fourth. So you need to rule out that these patients do not have tuberculosis, that these patients do not have HIV, they do not have hepatitis B, they do not have HIV. Only then you can start this patient on adalimumab or etanercept. This is anti TNF inhibitor therapy. Wonderful. Well answered. Okay, so where is rheumatology? Here is rheumatology. All right. So now we will do one topic which is such an important one that there have been many questions on this. That is relapsing polychondritis. The patient profile that will be coming will be usually a female coming to you with redness and tenderness of the earlobes since 2 weeks, since the winters have started, and they will tell you that they remember once they had a similar problem and they had difficulty in breathing and their voice quality also changed, and the doctor started them on steroids and they got better in 2 days. So this is a typical history given in the question for relapsing polychondritis. It is an autoimmune condition. There basically is cartilaginous inflammation. Now we remember that in rheumatoid arthritis also it is cartilaginous inflammation, but here it is no bone will be involved. It will be just the cartilages where in the pinna, in the nose and in the tracheal cartilage. So triggering factor could be a viral infection, a chemical toxic exposure or a direct injury, but usually the relapsing polychondritis have been reported after ear piercing, which is a very common thing for women to get done. There is the theory that the cryptogenic antigens, they are released into the circulation when the cartilages are pierced at the junction of the basically the blood and the cartilaginous membrane barrier. So when these autoantigens they are exposed, the autoimmunity develops, leading to polychondritis. This is why, although the piercing was done in the pinna, but inflammation happens everywhere in the trachea, in the nose, and the sinuses. So there is an association of HLA-DR4. Any other condition associated with DR4?
This rheumatoid arthritis.
So exactly, this is why I always say rheumatoid arthritis and relapsing polychondritis, the name is RA and RP, and both of them are HLA-DR4 associated. The only difference being in rheumatoid arthritis, the bone also gets involved, but in relapsing polychondritis, it is just the cartilage that gets involved. So immunity is usually against the proteoglycans, which is the main constituent of cartilage. There is circulating and tissue-specific antibodies against collagen types 2, 9, and 11. Diagnosis is basically through McAdams criteria, radiographic findings, and biopsy of the cartilage. I've boldened it because this is gold standard. We need biopsy of cartilage, very important. So three things. One is clinical criteria. What are those? We need 3 out of these 6 criteria. One is there has to be a proven recurrent chondritis of both auricles, that is pinna. There should be non-erosive inflammatory arthritis. What type of arthritis is there in rheumatoid arthritis? Erosive or non-erosive?
Erosive.
So it is erosive. All right. New students, can you tell me how about SLE?
Non-erosive.
Okay. The previous students, now you can join in. So in SLE?
Non-erosive.
Yeah. So in SLE, the arthritis is non-erosive. That also can happen in case of relapsing polychondritis. Then chondritis of the nasal cartilage, and wherever other cartilages are present, like eyes, as conjunctivitis, keratitis, scleritis, uveitis. Then the respiratory tract with involvement of laryngeal or tracheal cartilage, and then of course the hearing and problems occur when the cochlear or vestibular cartilages they get involved. Out of these 6, any 3 if they are present, they characterize as positive clinical criteria for relapsing polychondritis. It doesn't stop there. You need a biopsy and radiographic findings. So biopsy of the auricular cartilage is to confirm the diagnosis of polychondritis. It is very important. As I told you, rheumatoid arthritis and relapsing polychondritis can go hand in hand. RA factor, the rheumatoid factor will be positive, may be positive. ANA also can be positive. Complement levels are usually normal in these patients. Anti-type 2, 9, and 11 are also positive against these collagen types. Radiographic findings are, remember, it has to be non-erosive. Everything else is just like rheumatoid arthritis, that is juxta or articular osteopenia, and uniform joint space narrowing will be there. If they are suggestive of arthropathy.
It's there. Is it up?
The treatment basically is steroids. You have to remember that. You have to act fast and hit hard. Why? Because otherwise they can choke to death. So patients who are presenting with whatever symptoms, you have to stage the disease on the severity index. So if it is a very severe disease, treat them with IV methylprednisolone. IV methylprednisolone, 1 gram for 3 days, followed by oral prednisolone along with immunotherapy if it is required. What kind of immunotherapy? It is basically DMARDs like cyclophosphamide, methotrexate, azathioprine, and cyclophosphamide. These are wonderful drugs. Initiate with cyclophosphamide, and after the remission is achieved, switch over to something else like MMF, methotrexate, azathioprine. And if it is not responding and the patient is again and again having a recurrent disease, then TNF-alpha inhibitor infliximab can be given. In worst case scenario where due to recurrent inflammation, scarring has happened, the patient may require airway stenting, airway dilatation, ballooning, tracheostomy, or everything which is there. Is that clear? Yes?
Doubt, it should be bilateral involvement of venous, or can it be unilateral?
Oh, can you be a little louder, please?
No, is it only?
I can't. You are not audible.
Am I audible now, sir?
Yeah, better.
Yeah. Do that need to be a bilateral involvement of pinna to diagnose it, or it can still be a unilateral one?
So let's go back to the McAdams. There is recurrent chondritis of both auricles.
So it should be both. Is it so?
Yes. Yes.
Yeah.
Okay. So the first criteria is recurrent chondritis of both auricles. Both of them should be involved. Any other question?
Yes, sir. Please repeat this. Erosive and non-erosive.
Say again.
Erosive and non-erosive. SLE for diagnosis.
Yeah.
Previous one.
Acha, you want the difference between erosive and non-erosive?
Yeah.
Okay. So basically, it is a radiological finding that you find this erosiveness is seen in rheumatoid arthritis mainly because there are punched out lesions and then eventually pannus formation and the joint is destroyed. But in case of SLE and these conditions, the joint is never destroyed because the erosiveness is not there. Okay. So that erosiveness or non-erosiveness is a radiological finding. It is a radiological criteria, characteristic. Okay, once you do an X-ray, you find it leading. So you see bone erosions. Like there was a bone. Maximum bone erosions you see in which kind of arthritis? Anyone? Anyone?
Yes.
The previous students? Maximum bone erosions you see in which kind of arthritis?
Psoriatic.
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 So
Psoriatic.
it is psoriatic arthritis, and
Yes,
it is that is why it is known as arthritis
Mutilans.
mutilans. So basically, erosion is like you see, what is that word where there were trees and you took out the trees and the soil got eroded, isn't it?
Yes, sir.
Soil erosion. Same way, the bones start getting eroded from its normal place. So there are three types of arthritis which have erosions in them. One is rheumatoid arthritis, second is psoriatic arthritis, and third is a variant of osteoarthritis which is called erosive osteoarthritis. All other in SLE, it is arthropathy. It is never arthritis. Are you sure? Oh, are you clear now?
Yes, sir.
So in SLE, Sjogren, these are classically non-erosive. These patients may have swelling of the joints, but these joints never deteriorate because there were no erosions. Is that clear, doctor? The one who asked the question?
Yeah.
So basically, you need to get an X-ray done, and on X-rays, you can find the erosions. They are aggressive arthritis, and they can lead to permanent joint deformity. So these are the things that you need to remember, that erosive arthritis is basically where the bone gets eroded, and due to erosion, there is healing and everything, and then restructuring of the bone, and then eventually uh, the what do you call it, bone deformities and eventual joint destruction. So these are seen in rheumatoid arthritis, psoriatic arthritis, and erosive osteoarthritis. Is that clear?
Yes, sir.
Fine. Yeah?
Yeah.
Yeah.
Great.
Yes, sir.
So now we move on to a very different type of an autoimmune disorder, Sjogren syndrome. So in Sjogren syndrome, basically it presents like rheumatoid arthritis, but you might be surprised to find that there are other element involved, like the eyes are dry, the mouth is dry, there are oral ulcers. Then you start thinking, maybe it is more than rheumatoid arthritis that I'm dealing with. So that is where Sjogren syndrome comes into place. So I don't know how many patients in the world are wrongly diagnosed as rheumatoid arthritis when they actually have Sjogren syndrome. And the matter of interest is that because the treatment is same in both of them, some people just never get diagnosed with Sjogren. The only thing is that if you tell the patient that you have Sjogren, there are chances for you and them to understand that they will not have their joints destroyed. Because in rheumatoid arthritis, the joint destruction is a fact. And if you don't intervene aggressively, the joints may be destroyed. So, Sjogren syndrome is basically an autoimmune inflammation of the exocrine glands. So, there is lymphocytic infiltration. Remember, it is lymphocytic, not T cell infiltration. So the lacrimal and salivary glands are importantly and commonly involved. There is something known as primary Sjogren syndrome, where it is mainly only the glands that are involved, no connective tissue. And then there is secondary Sjogren, where Sika syndrome is also present with rheumatoid arthritis. Females are obviously more involved. The HLA association is DR52. The aggregation is basically lymphocytes and CD4, but no cytotoxic. That is, CD8 cells are never seen, and memory cells, because this is antibody-based disease. The inflammatory cell gathering leads to eventual glandular neurodegeneration from apoptosis. There are certain associated conditions that you should be worried about. One is primary biliary cholangitis, PBC, very common. Marginal zone lymphoma, viral infections like HCV, EBV, HIV, and one more thing, that is distal renal tubular acidosis. Why I'm saying it? So there was a question 2 years back that a young female presented to the hospital with weakness of both lower limbs. She was found to have potassium of 1.9. Despite IV therapy, IV replacement, the patient continued to have low potassium levels and eventually got intubated and had to be put on ventilator. Which autoimmune disorder may be there in this patient if you look closely enough? So the answer is Sjogren syndrome. Why? Because distal tubular acidosis will lead to persistent hypokalemia unless you treat this patient with steroids. Unless you treat this patient with spironolactone, this patient will not improve. And mind you, Sjogren syndrome, if you just put it up on the internet, in the Google, the association between distal RTA and Sjogren syndrome, you will find that most of the people in the world who have distal RTA, they also have Sjogren syndrome along with. Clinical features, they are basically from xerosis, that is dryness of the secretions from exocrine glands leading to dry mouth, hence the dental caries, enchilitis, xerostomia, stomatitis, xerophthalmia, dry eyes, vaginal dryness leading to dyspareunia, and pancreatitis because of the deposition of the pancreatic secretions inside the pancreatic duct leading to pancreatitis. Also, there are arthralgia and secondary arthritis, purpura due to cutaneous vasculitis, lymphadenopathy because of a possibility of lymphoma, glandular swelling, bilateral parotid enlargement is there, renal tubular acidosis leading to recurrent hypokalemia. Investigations, you need to check these patients for salivary gland scintigraphy, contrast sialography, Shermer's test. Shermer's test is, you know it all. I'm just trying to, not miss out on anything. So this is Shermer's test. You put in absorbent paper under the dry. If it comes out wet, or the litmus paper, if it comes out discolored, it is the tears are there. If not, if it comes out dry, then it is zero ophthalmia. And because of zero ophthalmia, there is corneal ulcerations. Hence, corneal staining is helpful. As far as the ANA is concerned, ANA is positive, usually more than 1:320. And in those ANA, if you check the extractable nuclear antigens, you find out the ROLA, that is NTSSA, NTSSB. So they are positive in this case. And mind you, as I told you, rheumatoid factor may also be positive in up to 90% of these cases. Biopsy confirmatory test is biopsy taken from lips or from labia, particularly in patients who have negative. So there are about 30 to 50% patients, almost half of the patients are there who may have negative anti-SSA and anti-SSB, but remember, it can be a clinical diagnosis that you can prove with the help of lip biopsy. ESR CRP will reflect disease activity, and many times a patient who was being evaluated on the lines of multiple myeloma may actually have Sjogren syndrome. So in the LFT, you look at the total proteins, you say, okay, 9, albumin is 3, and globulin is 6, with ESR of 120, slightly elevated creat of 1.6, but a normal calcium. So you do a bone marrow and you don't find anything, no plasma cells. So basically, it could very well be Sjogren syndrome, because the patient can have polyclonal hypergammaglobulinemia and they respond very well to steroids and DMARDs. Is that clear? Every line in these notes is important because it has been asked in the exam. So whenever you see a polyclonal hypergammaglobulinemia, you think about Waldenstrom's, you think about multiple myeloma, you think about this monoclonal gammopathy of unknown significance. But remember, you also have to keep in differential Sjogren syndrome. Okay?
Okay, sir.
So the treatment will be artificial tears, moistening sprays for mouth, and if the patient has arthritis, treat them with HCQS. If they have recurrent hypokalemia and polyclonal hypergammaglobulinemia, then the DMARDs will come handy. So all you need is methotrexate, azathioprine, and yes, the big kings, steroids. So everything is doable. So the point of note here is that anti-Rho and La, they are notorious small-sized antibodies which can cross from placenta, and they have affinity for the conduction system of the heart. They damage it, leading to neonatal heart block. Okay? So neonatal heart block can be seen. There is 40 to 60 times risk of development of non-Hodgkin's lymphoma. All right. Okay, fine. Now we come to vasculitis. Okay. Can anyone tell me what is the classification of vasculitis? Who classified? What is the classification system for vasculitis known as? Because this was asked in one of the exams, and so it is called Chapel Hill classification. Please remember it. It was asked in the exam, which of the following in true and false? So the problem is Chapel Hill classification. If you are not read it, you will not be very sure that Chapel Hill classification is used to classify vasculitis. Now, why do we need a classification? That is very important thing to know. Because there are different types of blood vessels in the body. So there are arteries, there are veins, there are capillaries. So it's just like there are 3 major classifications, but in the arteries also there are classification: large sized arteries, middle sized arteries, and small sized arteries. So the point of intrigue is that these conditions can actually be clubbed into the size variability dependent disease process. That means in certain patients, it is only the large arteries which are involved. And in certain conditions, the large arteries will not be involved. So you can actually Focus on who to treat, when to treat, how to treat, based on the involvement of, and if you can prove that these arteries are involved. So, why? Because if it is the aorta that gets involved, imagine if aorta gets involved, then patient can have aortic aneurysm, aortic regurgitation, aortitis, and these patients can die very fast. So you will not get maybe a week to treat these patients. Then there are patients who have middle size, like renal arteries are involved. Then these patients will have gradually or rapidly progressive renal dysfunction, or they can have the arteries providing blood to the orbit of the eye. That means this patient can become blind if you don't treat them fast enough. So, and then there are certain small vessel involvements like digital gangrenes, like we know Raynaud's disease. So unless you act fast and act smartly enough, you may not be able to treat these patients, and you will lose those patients or their organs. So the problem is with the inflammation and necrosis of blood vessels leading to impairment of the blood flow. So it may lead to weakening of the blood vessel wall, aneurysm formation, or formation of a thrombus within the lumen of the blood vessel. Usually, the injury is mediated either by the T cells or by the immune complexes, or it is posse-immune. Posse-immune is where you don't find the classical antibodies anywhere, or the classical antigen antibody complexes anywhere. So they are basically ANCA-mediated vasculitis. And then there are certain antibody-associated diseases like anti-endothelial, and then there are certain bad diseases like HIV, which can lead to direct endothelial injury leading to the disease. So, cell mediated or T cell valid diseases, they are giant cell arteritis, Takayasu's, or primary CNS vasculitis. Primary CNS vasculitis is characterized by recurrent strokes. Imagine recurrent strokes, and the neurologist is treating these patients with aspirin, with statins, and still these patients continue to have stroke. They keep on adding drugs, and the strokes keep on happening because the problem is not with the thrombi formation. The problem is with the inflammation of the walls. Unless you treat the inflammation, you will never be able to prevent the thrombosis from happening. Then immune complex mediated, that is immune complex mediated. So this is the whole thing. There is an antigen, there's an antibody, both of them combine together, and then they get deposited anywhere, leading to diseases like PAN, inoxanoline purpura, cryoglobulinemic vasculitis associated with hepatitis B usually. Then ANCA mediated are GPA, EGPA, MPA, and anti-endothelial antibody diseases like Kawasaki's, Behçet's disease. And then comes the Chapel Hill classification, which is basically based on the size of the blood vessel that is involved. It could be large vessel vasculitis, for example, Takayasu, for example, giant cell arteritis, where the limbs can get gangrene, asymmetric blood pressure, absence of pulses, thoracic aortic aneurysm. So the large vessels are involved. Temporal headache, jaw claudication, blindness because of the extracranial branches of the carotid artery are involved. So this is how the large vessel uh, vasculitis will present. Pain of the legs, rest angina of the legs, asymmetrical blood pressure, absence of random pulses in the limbs, thoracic artery, aortic aneurysm, temporal headaches, and all these things. Medium vessel vasculitis, they will be seen in polyarteritis nodosa or Kawasaki's disease. This will present with digital gangrene, digital ulcers, libido reticularis, nodules in the skin, mononeuritis multiplex, very important. So, ulnar nerve is damaged, median nerve is damaged, there is a foot drop in the same patient, but temporally and spatially different. So you will know that, okay, first one nerve was involved, and second got involved, and third got involved. Imagine this is inflammatory disorder, and it is not a neural problem, it is a vascular problem because these nerves, they are big nerves, they require vasa nervosum, which is the blood supply of these nerves. It gets involved, and eventually the nerve gets deprived of the blood supply, and hence it is the individual nerve that dies off, and then leading to mononeuritis multiplex. Then renal artery involvement leading to renovascular hypertension and organ infarctions like splenic infarction and all. Then comes small vessel vasculitis, in which is a very small vessel like ANCA vasculitis, Wegener's, EGPA, microscopic polyangiitis, immune complex vasculitis like good pasture. Good pasture is basically anti-glomerular basement membrane antibody. So it will present with palpable purpura, urticaria, glomerulonephritis. When I say glomerulonephritis, I need you to understand that the patient will be presenting with hematuria, nephrotic or nephritic syndrome with hypertension. So maybe nephritic more, nephrotic less. Alveolar hemorrhage, as is seen in good pastures, and scleritis. Then there are certain variable vessel vasculitis, for example, Behçet's, which can involve any of the blood vessels in the body. Single organ vasculitis like aortitis, Takayasu, Kawasaki, CNS vasculitis, vasculitis associated with systemic disease like rheumatoid arthritis associated, sarcoid vasculitis, and HCV cryoglobulinemic vasculitis. So this is just the classification, okay? Now we go on to individual diseases. So giant cell arteritis, very common and very, very pertinent, very, very pertinent and very, very recurrent. You will find at least 3-4 questions from giant cell arteritis in the exam. So many times people confuse it with PMR when it is just that it is associated with PMR, polymyalgia rheumatica. So they are not interchangeably used. You have to understand that in polymyalgia rheumatica, giant cell arteritis may be present. So giant cell arteritis is usually seen as the pain in the temples of the head, that is on the temporal arteries will be involved, is a systemic medium and large vessel vasculitis with particular predilection for extracranial branches of the carotids, leading to focal and granulomatous inflammation. And when I say granulomatous inflammation, it is T cell associated. Remember this very clearly. Females are more involved, age more than 50, and HLA-DR4. So many times RA factor may be positive also. Features are unilateral headache, usually 70%, jaw claudication, fever, unexplained fever for last 20 years. Patient has giant cell arteritis. Amaurosis fugax. Patient will tell you that last week I lost my vision, it came back, but then I see that I am having blurry vision again. So the ACR diagnostic criteria are there, which gives us 90% and more sensitivity and specificity if more than 3 are present. One, age should be more than 50. Second, patient should say, fine, I have a new onset localized headache. It is there in my right side of the head. It is just above my ear, and it is pulsatile headache. The ESR I got done was 50 and above. Temporal tenderness. When you press on the temporal side of the head, it hurts. Patient can tell you that I can feel the pain here. And you do a biopsy, although there are skip lesions, but if you're lucky, you can actually get a biopsy. So large segment temporal artery has to be excised. Why? Because to mitigate the skip lesions and arrive at a diagnosis. Diagnosis is ESR, CRP usually raised, but yeah, I mean, patient may have polyarthralgia, but this is non-erosive again, and the patient may have RA factor positive, but then usually you don't give it much attention. But then these are females above 50 years of age with decreased sleep, with decreased focus, pain, and polymyalgia, just like the proximal girdle is involved. You can do a color Doppler ultrasound, and on palpation, the temporal arteries feel different. You can feel them like a cord, and you take a biopsy, it confirms the diagnosis. And there are mononuclear infiltrates or granuloma. So it is a granulomatous inflammation. Normal biopsy does not rule out this diagnosis because there may be skip lesions in your way. Okay. So, am I audible? Hello?
Yes, sir.
Great. So, you have to stage the disease. You have to stage the disease. If the patient has only, oh, where did my screen go? You have to stage the disease. In case the patient has MRCP fugax, that means the patient is at high risk of blindness. Then the treatment is intravenous steroids. But if they just have temporal inflammation and ESR is elevated and you don't find anything, then you start them on oral prednisone. Okay? So please read the question very, very carefully. If it has mentioned that there is a blindness or there is a visual blurring or there are chances of stroke, only then give intravenous steroids. Otherwise, oral steroids are perfectly fine. Oral steroids starting at 1 milligram per kg. So 60 kg lady, 60 milligram dose per day, gradual tapering. IV methylpred if the visual impairment or stroke risk is high. Taper slowly but continue for at least 12 months. Do not wait for biopsy. So it does not mean that you have to continue with 12 months for IV steroids. You just give IV steroids for 1 week and then you can go on to this dose of oral steroids. Complications, irreversible blindness, usually up to 10% patients will never regain. Aortic aneurysms, aortic regurgitation, ischemic strokes, and recurrence. Yes, up to 40% will relapse within 2 years. Then another big wig, polyarthritis. We'll do the questions. Please give me some time so that we can just finish the topic first and then we'll take up the questions. Polyarthritis nodosa. If you want, we can do the questions alongside, but then that will be a little lengthier. Is that okay with you if you finish the topic first?
Yes, sir.
Yes, sir.
Fine. So polyarthritis nodosa, as I told you, medium-sized blood vessels are involved. You have to understand that most of the body is being supplied by medium-sized arteries, be it digital arteries, be it spleen, be it kidneys, be it the genital system of the body. So wherever the liver, wherever the major organs are involved, polyarthritis means, poly means multiple, arthritis means inflammation of the arteries. Nodosa means there is necrotizing inflammation. So nodes are formed inside the blood vessels which are necrotic. So it is a vasculitis affecting medium-sized blood vessels. There is necrotizing inflammation and generalized aneurysms are formed in the blood vessels. This is one rare condition of autoimmune world where men are involved more. Middle-aged men, they are more involved. This is one such condition in rheumatology where the question statement will start with a 40-year-old man who was diagnosed with hepatitis B 2 years back has now come to you with constant pain in the right hypochondrium and new onset hypertension. So look for these magic words: 40-year man, hepatitis B diagnosed, comes with right hypochondrial pain. Don't think of gallbladder stones, okay? The story is building up with these things. Hepatitis B, right hypochondrial pain, testicular pain, testicular pain, or calgia it is known as, and new onset hypertension, not responding to multiple drug combinations. Think of polyarthritis nodosa immediately. And they can give you a cake if they give you that the patient also had digital gangrene. You are done with the diagnosis then. So it is vasculitis of medial sized arteries. There is necrotizing inflammation. Middle aged men are involved. Hepatitis B is the regular association. Others can be HCV and hairy cell leukemia. ANCA is classically negative. Negative. Many people ask me, sir, we have remembered PAN as PANCA. Fine. But then it should be negative. I mean, you remember it fine. But then as far as the data goes, ANCA is negative in polyarthritis nodosa. Presentation, fever, malaise, arthralgia, hypertension, capital letters mein likha. It will always be there in the question. Look for it. Mononeuritis multiplex. Okay, they might tell you that there was a recent foot drop, which was worked up nicely, but nothing could be found. Sensory motor neuropathy, mesenteric ischemia, pain, abdomen, GI bleed, non-alcoholic, still GI bleed, no ulcer, no history of painkiller abuse. They are asking you to diagnose polyarthritis nodosa, genitourinary, testicular pain, hematuria, renal failure. So much so that testes may be a site for biopsy for diagnosis. There are diagnostic criteria laid down by American College of Rheumatology, and it has not changed since 1990. Although there are 10 different criteria mentioned, you only need 3 to make a diagnosis. I've given you so many of them. I've given you 40-year-old man, hepatitis B, right hypochondral pain, testicular pain, new onset hypertension, digital gangrene, foot drop. Let's see if I can find. Weight loss of more than 4.5 kg, libido reticularis, we all know. Testicular pain, from my question, it is there. Okay. Muscle pain, weakness, and leg tenderness. Nerve disease, single or multiple. My patient had a foot drop. Diastolic BP of 90, third criteria. So 3, you need to make a diagnosis of PAN. Deranged renal function test, hepatitis B positive. My patient also had this. 4. Abnormal angiogram, biopsy. They will not give you ever biopsy, but then you must know that biopsy, positive biopsy is one of the criteria. Evaluation, you can do a whole body angiography. You can find microaneurysms in kidneys, in mesenteries, hepatic arterial branches, or you may get a affected organ biopsy from liver, from kidney, from spleen, from testes, anywhere. ESR, CRP are obviously increased because of the inflammation. Treatment is high-dose corticosteroids to suppress the inflammation, followed by the cyclophosphamide and eventually non-steroidal DMARDs. Is that clear about polyarthritis nodosa? Will you be able to identify the patient in the question?
Yes.
Great. Now coming to Vigeners. Yes, any questions?
Yeah, no, sir. The most common is nephritis, glomerular nephritis is not common in PAN, and lungs are not involved. These two should be used as to rule out PAN.
Yeah, so the pulmonary involvement is not usually there, and that is because, can you tell me why
It's a
these
large,
2 organs are classically not involved? By
larger arteries.
larger arteries, and another reason, because they are
ANCA positive.
no.
ANCA negative, sorry, sir.
Yeah, so if ANCA would have been positive, these 2 organs will also
These two
get
would have
involved.
been involved, yes.
Yeah, okay. So this is very important to remember. Oh, Vigeners, we cannot mention it here on this page. We mentioned ANCA negativity on a wrong page. Okay, fine. So very nicely put. So these PAN, this will never have kidney or pulmonary involvement. Okay. Any other thought?
Because I have seen a patient with an MI and a PAN.
Yeah. They can have strokes, they can have MI, they can die of gut gangrene. I don't know how many times we've told the surgeons to get the patient evaluated, but they never do it. They just remove the gangrene and send the patient home, and there is no follow-up thereafter. Many times this gut gangrene, the underlying disorder is this. And you can actually come across, these are 40, 50 years old male coming with pain abdomen who was hepatitis B or hepatitis C positive, and when they do an exploratory laparotomy, they found out a gut gangrene. This could very well be PAN. All right. So we move on to the next bigwig, that is Vigeners granulomatosis. So do we have anything else here? No. Okay, Vigeners granulomatosis. So Vigeners is no longer known as Vigeners. Now it is known as granulomatosis with polyangiitis. So there are small and medium vessel involved, and there are granuloma formation. Also, these granulomas are so notorious that they not only involve the blood vessels, they go on depositing in the My drawing is weird, but then they can get involved. The nose of the patient. So there is a saddle nose deformity. So the granuloma gets deposited here and then it damages the nasal septum. And then, of course, the lungs and the kidneys. So these are one of the renopulmonary syndromes. So upper and lower respiratory tract, hemoptysis will be there, epistaxis will be there, and hematuria will be there, nephritic syndrome will be there. So kidneys will be involved. This is combined antibody and T cell mediated injury. The T cells happen to form the granulomas and antibodies tend to do the damage via C-ANCA, which is anti-proteinase 3, 90 to 95% sensitivity. Patients usually have sinusitis, recurrent otitis media, otalgia, destroyed bridge of nose nasal deformity, and sorry, it is not mentioned, it is epistaxis. Lower respiratory tract system involvement leads to hemoptysis, breathing difficulty, and cavitatory lesions in the lungs. So you need to know the differentials of cavitatory lesions of the lungs. Then renal symptoms will be hematuria. Skin, there will be necrotizing ulcers, palpable purpura, anything is possible. Labs positive C-ANCA, specifically it is anti-proteinase 3. Okay, elevated ESR CRP, biopsy of the active site, chest X-ray, CT chest, single or multiple nodules, masses plus minus cavitation, and the patient usually have a history of hemoptysis. Treatment is steroids, methotrexate, cyclophosphamide, rituximab, IVIG, followed by plasma exchange therapy. Complications of note are pulmonary hemorrhage and death, and you need to give them pulse therapy with steroids. And if the patient has pulmonary hemorrhage, the treatment is plasmapheresis. Is that okay? All right. So just like Vigeners, the another condition is EGPA. EGPA is eosinophilic granuloma polyangiitis. It used to be known as Churg-Strauss syndrome. Usually the history of long-standing bronchial asthma will be there, and it is also renopulmonary syndrome, so kidney and lungs will be not involved. Similarly, the treatments are the same: steroids, methotrexate, cyclophosphamide, and the positivity of ANCA is P-ANCA for Churg-Strauss. Okay. All right. So just for your revision here, just for a fast revision so that we can eventually read the questions. So giant cell arteritis affects the large arteries, particularly temporal. Headache, scalp tenderness, jaw claudication, visual disturbance, polymyalgia rheumatica association, and HLA-DR4. Elevated ESR, CRP, temporal artery biopsy, don't forget the skip lesions. And treatment is steroids, high-dose steroids. IV steroids are given if the patient is having ocular symptoms. And remember, do not wait for biopsy to start steroids. Immediately give IV bolus of steroids. You can always do biopsy later within the first week, but do not delay the giving of steroids because the patient may lose the light of their eye permanently. Then we missed out on that Takayasu's arthritis. Takayasu arthritis affects the aorta and main branches. So presence and absence of pulses is important. So palpate all the pulses. Usually in young women of Asian descent, there are diminished pulses. So whenever the pulses are a problem, think of Takayasu. Blood pressure discrepancies, claudication, visual disturbances. Diagnosis is by whole body angiography. Treatments are steroids and immunosuppressants. Polyarteritis nodosa, medium-sized arteries, sparing smaller vessels and the lungs. Clinical features, systemic symptoms, fever, weight loss, skin lesions, hypertension, renal failure, peripheral neuropathy, mononeuritis multiplex. Diagnosis, biopsy. So there will be necrotizing granulomas, angiography showing aneurysms, treatment, steroids, immunosuppression, cyclophosphamide, all of them. Kawasaki's disease. Medium-sized arteries, usually it is the children which are involved. Don't confuse with Takayasu. Young females. Young females. And Kawasaki's are children. So you will not get a question from Kawasaki because it is adult medicine which is asked in MRCP, but there are sometimes they'll just mention it as one of the choices in the question. Fever, conjunctivitis, rash, lymphadenopathy, mucosal changes, and coronary artery aneurysm. So young children, small children coming with coronary artery disease, always rule out Kawasaki's. Diagnosis is clinical, therapy, IV, immunoglobulin, and high dose aspirin. How much aspirin? 1 gram per day. How much aspirin? 1 gram per day. Then GPA, which is Wegener's. So small vessel, granuloma formation, upper and lower respiratory tract, glomerulonephritis, skin lesions positive, C-ANCA, biopsy shows granuloma, steroids, rituximab, cyclophosphamide, plasma pheresis, microscopic polyangiitis, small vessels but no granuloma. It is also P-ANCA positive, just like this EGPA. Steroids, rituximab, cyclophosphamide, it is pulmonary renal syndrome. Always remember microscopic polyangiitis, hemoptysis, glomerulonephritis, systemic symptoms. Churg-Strauss is eosinophilic granulomatosis with polyangiitis affecting small vessels, and the granuloma will have eosinophils in it. Asthma and allergic rhinitis history is there. Eosinophilia will be there. Peripheral neuropathy will be there. Elevated eosinophils, positive P-ANCA will be there. Corticosteroid and cyclophosphamide and plasma therapy, these are the treatments. Hinox-Noline purpura, IgA vasculitis, usually we do it in skin dermatology and nephrology, but as a vasculitis part, we'll read it. It is small vessels only, usually after an upper respiratory tract infection. Can anybody tell me why after an upper respiratory tract infection? Why?
IgA secreting mucosal.
Yeah, so IgA basically, wonderful, thank you. So IgA is also known as mucosal antibody. So whenever there is a upper respiratory tract infection, excess IgA is produced. And this excess IgA gets deposited with the antigens in the basement membrane of the blood vessels, leading to IgA vasculitis, and also in the glomeruli as linear deposits, leading to IgA nephropathy. So diagnosis is clinical. Patients usually present with the palpable purpura, usually leukocytoclastic vasculitis, arthralgia non-blanchable purpura, arthralgia, abdominal pain and hematuria. Treatment is supportive, steroids, and sometimes immunosuppression is required. Then comes cryoglobulinic vasculitis. So these are the cryoglobulins which precipitate in the colder part of the bodies, affecting small vessels. So usually peripheral neuropathy, glomerulonephritis, HCV association is important. Diagnostic positive cryoglobulin levels. Low complements are there because the complements are eaten up during deposition in the peripheral parts of the body. Treatment is antivirals. Imagine no steroids, but you can give immunosuppressants along with antiviral therapy if it is associated with HCV, but usually they are associated with hepatitis C. Are we all clear about the vasculitis?
Yes.
I specifically dedicated so much time to vasculitis. The reason being, we all read rheumatoid arthritis, SLE, Sjogren syndrome, scleroderma, sarcoidosis, and everything, but we always forget reading about vasculitis. And if we do read about Wegener's granulomatosis and Churg-Strauss, we forget that they are vasculitis. That means they involve the blood vessels, and we usually forget reading polyarthritis nodosa, which is a very important topic, and it will definitely come in your exam. So I would like to have contribution from everyone. A 70-year-old woman presenting with 4-week history of headache, scalp tenderness, and jaw pain while chewing. She has experienced blurred vision in her right eye On examination, right temporal artery is tender and thickened. Her ESR is 85. What is the most likely diagnosis?
Yes.
James Rapids.
What is the treatment for this patient?
This
Steroids. IV steroids.
Steroids.
IV?
Methylpred.
Steroids.
What
Methylpred.
IV? Methylpred.
Prednisone.
So be very, very specific. Okay. What is the dose?
1 gram
One
for 3
gram
days.
per day for 3 days.
So 30 milligrams per kg per day. You might be required to give 1800 milligrams for a 60 kg old 60 kg woman. Okay.
Okay.
All right. Okay. Question number 2. Oh. Okay. A 5-year-old boy presents with a 7-day history of fever, conjunctival injection, cracked lips, and a maculopapular rash. His parents are concerned because his hand and feet are also swollen. Laboratory workup reveals increased platelet count, thrombocytosis. Echo shows a coronary artery aneurysm in the LAD. What are we dealing with?
Kawasaki.
Kawasaki's disease. So Kawasaki's disease it is. So how will you treat this patient?
IVIG and aspirin.
Aspirin and immunoglobulin.
So what is the dose for aspirin?
1
1
gram.
per kg.
Per
One-
day.
Per day. All right. Okay. A 45-year-old man with 45-year-old man with history of asthma, presenting with worsening shortness of breath, weight loss, numbness in his legs. Lab results show eosinophilia, positive P-ANCA. A biopsy of sural nerve reveals eosinophilic vasculitis. What is this?
EGP. Church stuff.
If there is no Church-Strauss in the answers, please
EGP.
excuse me. Yeah, because now the terminology has changed. So the answer is
EGPA.
EGPA. So how will you treat?
Eosinophilic granulomatosis.
Steroid.
Okay.
Rituximab.
Steroids.
So we will give steroids followed by cyclophosphamide. If doesn't work, then CD20 inhibition, that is rituximab. And if that also doesn't work and the patient on day 7 starts to have hemopsis,
Plasmapheresis.
Plasmapheresis.
then the answer is plasmapheresis. Okay. Next question. A 30-year-old woman presents with hemopsis and hematuria. So what is this known as? Hemopsis and hematuria?
Renal and
Pulmonary renal.
Pulmonary syndrome.
Renopulmonary.
Renopulmonary.
She has had fatigue, weight loss, and arthralgias over the past few months. Her urinalysis shows RBCs. Chest X-ray reveals bilaterally pneumonia. I will not say pulmonary infiltrates because they will like to complicate you. So bilateral pulmonary infiltrates or bilateral pneumonia, bilateral lung involvement. Her C-ANCA is positive, 1:80. So what is the likely diagnosis?
GPA.
GPA. So what is the treatment?
Steroid. And
Steroids. Yeah.
this cyclophosphamide.
So she has hematuria and hemopsis, and you start directly with steroids plus cyclophosphamide. In case it doesn't work, then just go to, because these patients, they get ventilated very fast. So just move on to plasmapheresis. Okay. Okay. So this brings us to the end of our class. If there are any particular questions with you, you may ask. Random questions also you can ask. Don't worry. You want to see Chapel Hill classification? I have this nice photo for this. Chapel Hill's classification. Not that it is going to be asked in the exam, but I just it.
Excuse me, sir.
No, we didn't
Yes.
talk about the Beckett, sir. It's a vasculitis. We know.
Oh, yeah. Bechet's disease is important. Let me just check if I have it with me.
It's a capillary disease.
The
Venous.
chapter in classifications. That slide.
Is it this one?
Yes. I want to take question.
You want to? Okay, let me clean the photo. Yeah.
Thank you, sir.
So let's do Bechet's disease.
Yes.
So I'll try to find if I can find an empty space anywhere. Khali paper. The thank you slide. Okay. So very important. You're right. I missed out on that. So Bechet's disease.
Excuse me, sir.
Yes.
Can I ask one doubt? Is this class available? It will be the record version available in the app, sir? Because
Sushmita can answer that better.
I missed.
Sushmita
I came in between.
will be there.
Yes,
It's a recorded session.
Yes, sir. It's a recorded session.
Okay, thank you, madam. Thank you.
Okay.
Okay. Yes, sir.
So students,
Thank you,
Bechet's
sir.
disease. Bechet's disease. So Bechet's disease is basically again an autoimmune vasculitis. It is a chronic inflammatory disease. We don't know the reason. We don't know why it happens. So there is basically vascular inflammation, and it may involve several organs, but presentation we all know is mainly oral ulcers. Then the patients usually have uveitis, and along with that they have penile ulcerations also, genital ulcerations basically. So there is a hallmark test which is known as
Pathargy's test.
So there is a hallmark test which is known as a Pathargy's test. Can anybody tell me what is Pathargy test?
If a line is drawn on the skin with a sharp object on skin prick, there is some hypersensitivity reaction along that line.
Wonderful. So all you need is a needle. So you take the arm of the patient. I don't think it is an arm, but then so you take a needle and then you scratch it like this. And what you see, so or you just do a puncture, small puncture here. Either you scratch or you do a puncture. What you see is over next 24 to 48 hours, there will be a reaction. There will be a red bump, just like a wheel and a flare reaction. Or there may be formation of multiple pustules along the line where you have scratched the skin. So this is basically indicates an exaggerated inflammatory reaction to trauma. So this is Pathargy's test. So a positive Pathargy test usually is seen in Bechet's disease. Okay. So after the Pathargy test, what else do you need to know? The organs involved. So what organs are usually involved? As I told you, it is the genitalia, the oral ulcers, the genitalia, oral ulcers, the eyes, and very importantly, skin. So in skin, what do you have usually? You have
Erythema nodosum.
erythema nodosum, and sometimes on the hands and soles of the feet, one can have some keratoderma balenorhexicum like lesions, which are the papulopustular lesions. Okay? Rarely patients may have seizures. And when they do have seizures, this condition is known as, it just changes its name, it becomes neurobechet. Rare, very rare. Okay? Is it clear till now? The Bechet's disease?
Yes.
So
Yes.
what are the diagnostic criteria? Number one, the patient should have, most important is, when do you start thinking of Bechet's is when the patients have
Oral and genital.
Ulcers. Oral and genital
Development
ulcers.
orogenital ulcers with scarring.
So the point is that you start thinking of Bechet's disease when the patient has oral ulceration. This is the center point. Then, along with that, they might have two other features. A, genital ulcers. B, skin lesions like erythema nodosum, keratoderma melanoregicum. C, eye lesions, that is uveitis. Or D, positive pathargy test. So, genital ulceration is a sub criteria. The major criteria is that oral ulcers have to be present. If the oral ulcers are present, only then you look for a genital ulcer. If genital ulcer is there, you say 1 + 1. If skin lesions are also there, then you say 1 + 2. If eye lesions are also there, you say 1 + 3. And all the patient needs is oral ulcers, oral ulcers plus 2 of these symptoms. Is that clear? So what is the cardinal symptom of Bechet's disease? It is
Oral.
oral ulcers. So fine. So you've done, the diagnosis is there. You've done the pathargy test, everything. You have the diagnosis. Fine. Then how do you treat it?
Steroid.
Okay, fine. This is a very broad spectrum answer. Give me some better answer based on the staging of disease. So let us say it is a mild disease. Then it is only oral ulceration. What will you do? Give steroids?
No.
What will you do? You will do topical steroids. If it is oral ulcers plus uveitis along with genital ulcers, then yes, then oral steroids. Is that clear?
Yes, sir.
So don't get carried away by the term steroids. It is topical steroids only if it is a minor disease. It is definitely oral steroids if it is a major disease. Then, of course, you have to shift on to azathioprine or cyclophosphamide. Otherwise, colchicine is also a very good drug which is indicated in Bechet's disease. Do you want some MCQs?
Yes.
There are presentations with venous thrombosis.
Deep vein thrombosis is also.
It is a vasculitis which is along with venulitis. So DVT,
Venulitis.
even CVT can occur. That is known as neurobechet's. Okay. Now I'll have to create an MCQ. So let's find out. So we have, okay, Bechet's is also another condition where males are more, involved. That is another condition. So in rheumatology, it is ankylosing spondylitis and Bechet's disease, and another disease that I told you recently, that was
PAN.
These conditions are more common in males. Otherwise, it is a female predominant conditions which are seen in autoimmune disorders. All right. So let us say we have a 40-year-old man with recurrent painful oral ulcerations. Also complained of genital ulcers with intermittent eye pain plus blurred vision. He has a history of traveling to Thailand for a vacation. He remembers having painful red lesions on his legs when he was there in Thailand. He denies any joint pains, but says that he feels feverish and chilly. What is the diagnosis? What is the diagnostic test? What is treatment of choice?
Diagnosis is vicious.
Okay.
Diagnostic test, pathology test.
Okay. Treatment is, as you said, steroids. All right. So I will give you, that is why specifically. So the diagnosis is Behcet's. Why not writer's arthritis? Why not reactive arthritis?
Because fulfills all the criteria of vicious.
And also he did not complain of arthritis. No joint pains.
No joint pain.
So we cannot have a diagnosis of arthritis if the joint pains are not there. All right. I specifically asked you what is the diagnostic test. So there is no diagnostic test. I told you that pathology test you can do, but then it is a supportive diagnosis. It is not a diagnostic test. So diagnosis is clinical criteria, clinical based. It is a clinical diagnosis. So there is no single test that can diagnose the condition for you. Is that clear?
Yeah. Yes, sir.
Okay. So what is the referral that is needed? What referral do you need for this patient?
Ophthalmology.
Wonderful. So ophthalmology. Why?
Because this patient is eye problem.
Latent eye pain
So,
and uveitis.
okay. So why we are bothered? We are going to give them steroids. He will get fine. You only said that we will treat him with steroids. Why do we want to send the patient to an ophthalmologist?
Because it is a vasculitis, so there may be blindness.
Yes, very good. So it may not only be uveitis troubling the patient may develop blindness. You must send this patient to the ophthalmologist because he said, I am having blurring of vision. He did not say that I have red eyes. He said he has blurring of vision. So the patient has blurring of vision, he has vasculitis. There are high amount of chances that this patient may have a irreversible damage to the vision. Is that clear? So vision loss is a potential problem, which is a potential complication in this patient, which may be irreversible. You have to understand that vision loss in giant cell arteritis and Behçet's disease may be permanent. Okay.
But
All
the
right.
lesion
So
involvement is only in capillaries, no, sir? It is venulitis and capillaritis in Behçet's.
it may be
Still, it
small
can cause
artery.
visual. Still, it can cause visual loss, sir.
Yes, it can cause irreversible vision loss.
Irreversible.
Yes, yes, yes. It is very important. It is very, very important. Ocular involvement in Behçet's disease, even if they develop uveitis, can lead to very aggressive kind of a vision loss. Is that clear?
Because in
So,
giant cell, it is the major big vessel, major large arteries involvement, which
where?
can occur and cause. But Behçet's, it's in the venules.
Yeah,
So
but then
it takes a
in
longer
giant
time,
cell,
no?
yes,
Giant cell, sorry.
in giant cell arteritis, it is at the level of the extracranial branching of
Extracranial,
the.
yes, sir.
So the
So visual
patient can
loss is
have
earlier
stroke,
and
the patient can have vision loss because of the ischemic component more.
ischemic.
In Behçet's disease, it may be uveitis and panretinitis. The patient can have small vessels are involved, no, the capillaries. The retinal blood vessels will get involved and the patient will just have blindness over a course of 2 to 3 days. It is very
Okay,
aggressive.
okay, sir.
Yeah. Okay. So let us say this patient of ours, we gave this patient steroids, but this patient had glaucoma. So when the patient was given steroids, the patient's IOP started to rise and his blindness worsened. So you did a slit lamp examination. The ophthalmologist did a slit lamp examination. He said the interior chamber is clear. There is no uveitis. What will you do next? I mean to say, what therapy now will you give? So what is the answer?
Colchicine.
So this patient had glaucoma. You gave steroids, IOP increased, patient blindness, I mean blurring of vision worsened. The ophthalmologist said there is no uveitis. The interior chamber is clear, but the patient's intraocular pressure is elevated. You have to stop the steroids. So how are you going to treat this patient then?
Methotrexate.
So the answer is colchicine. Okay. So in such a case, the answer will be adding, substituting it for colchicine. Is that clear? Have you got the question or not? So you have to remember this, that these patients who are having Behçet's may have blindness because of recurrent use of steroids leading to glaucoma. Okay.
So how is colchicine going to help in this case?
So colchicine is basically where does colchicine act?
That tubule,
Microtubules. Okay.
microtubule formation, yes.
Polymerization of microtubule.
Yeah. So this is a vasculitis that occurs due to so when we were where were we? When we were studying the classification, let's find out where is the classification. So let's go back here. So it is anti-endothelial antibodies. The Behçet's disease because of anti-endothelial. That is, is there. All you need is to stop the multiplication of the B cells. That is how rituximab comes into play. That is how colchicine comes into play. Colchicine disrupts this pathway. It disrupts the multiplication of the B cells, leading to decrease in the antibody synthesis. So that is how it creates its immunosuppression.
Okay, sir. Thank you.
Okay. So this is how colchicine is effective in so many other conditions where we cannot use other drugs. So it is very good. In fact, if you go down into management of gout, how does colchicine help gout?
Yes, colchicine is the treatment for gout.
How does it affect gout?
It prevents polymerization of the urate crystals and does prevents its deposition in the joints.
Anybody else? So basically you have to understand that okay. So basically the this colchicine, this has a very good effect on neutrophil aggregation also. So the thing is, when the crystals are deposited inside the joints in gout, it is the neutrophilic migration which leads to inflammatory response. So colchicine, what does it do is basically disrupts the mobility of neutrophils by disrupting their microtubules. And these neutrophils, when they are eating up on the urate crystals, they release the inflammatory markers and inflammatory cytokines, and hence colchicine helps preventing the gout reaction. So when I'm telling you about the endothelial antibodies in Behçet's syndrome, the thing is that Behçet's also has, I was reading somewhere that when you take out the pus from the pathergy test, it is neutrophil rich. That the pus that is formed in the pustule, no, it is a neutrophil rich. So whenever we are using colchicine, that is how colchicine also plays a part in Behçet's disease, because not only it prevents the antibody formation from the B cells, it also inhibits the migration of neutrophils into the affected area.
Okay.
So but that is how colchicine.
Sorry, sir, but the papule is sterile, no, sir, in buckets?
Yeah, it is sterile. Sterile means there are no bacteria in it. It is a pustule. Sterile means the culture is negative. There are no bacteria in it. But because it is a pustule, there is pus in it. This is sterile neutrophils. Only neutrophils are there, and they have gathered because they feel that there is some, there is a threat. So let's get collected there. So this is enhanced inflammatory responsiveness. Just like in asthma, it is the airway gets closed. Yes, it is hyper responsiveness. So Behçet's is also hyper responsiveness to trauma. But the aggregates are neutrophils, and neutrophilic migration is prevented by colchicine. This is how it helps mainly in Behçet's disease, along with its effect on cytokine synthesis and antibody synthesis via B cell formation. Is that clear? Yes, so sir. that is why wherever neutrophilic involvement is there, we can use colchicine in a better way. Any other questions?
Thank you, sir.
HLA-B51 involvement.
HLA-B51, yeah, you need to remember that for Behçet's disease. Anything else that might have missed?
Thank you, sir. Good night.
Okay, doctors, take care.